This is a 16-year-old girl who landed up in our clinic with bilateral developmental, almost, it's a posterior cataract, and she's been blind for quite some time. No idea why they have delayed so long. However, they're extremely poor, so they approached a hospital and I went ahead, and initially after putting my phaco incisions inside put incision, I stained the capsule and I'm performing my probably 5.5 rexus, maybe a tad bit larger. So it's around a 5.5 and all is going on well. This was done quite some time ago, and my principles of doing these surgeries are changed. Anyway, here this is the way I did it at that time. I'm trying to do a hydrodelineation. Probably there was a bit of hydrodissection as well. Okay, no, just put in this. I am pressing on the wound lips as well, so as to keep the chamber a little under pressurized. However, I brought out the nucleus into the anterior chamber. I can see that it's rotating. Put in some HPMC and I take 2 dialers, and my idea is to prolapse this nucleus into the anterior chamber, as I don't think the bag is a safe option. This is a very soft, you can call it just an epinucleus in fact, and mostly with vacuum and very little phaco power for the central core. The entire complex is removed. That is a nuclear epinuclear complex. The case will also highlight some of my mistakes. This is done very long ago, and it's a good thing to revisit cases like this to see where you went wrong and what you could have done better. And here I am very slowly taking out the nuclear epinuclear complex, and I have come out. I have not even noticed. You can see now I have noticed that there is actually a oval tear there, rupture. Put in some HPMC, and the most important thing is first target all these small epinuclear bits before you actually go for the cortex. Target all the cortex and epinucleus or whatever which is free floating first. Get a bit, eat it up, and then only target the rest. And once that's done, then I go into the phonesis, and I engage vacuum only when I'm within the cortex. So very carefully go around. Try not to, my aim is not to enlarge the tear further. And there is no need to keep on putting HPMC. You can come out very carefully, not allowing the chamber to collapse. But if you put HPMC, yes, well and good, it's a better option, and I probably should have done that. Do not engage vacuum when you're close to that tear. Don't engage vitreous. So stay in irrigation, go towards the cortex, dig into the cortex, and then push into the second mode, that is into the aspiration mode. So only you are going to catch cortex and nothing else. Because if you enlarge this tear, then it is going to become problematic. Luckily here my iris itself has plugged the wound. So I am just releasing that with HPMC, making sure the chamber is not too pressurized but not completely flat. Now I have put in a lot of HPMC and the oval tear is stable, and it is up to me to keep it that way. So I am putting in a lens within the bag. I have to make sure when I am injecting I don't exert any pressure on that postcapsular tear. So I am going between the two leaves of the anterior and posterior capsule, very slowly injecting. My idea is to inject it directly into the bag, and the optic will act as a scaffold and prevent any vitreous from coming forward. And that's exactly what happened. And once that's over, I just aspirate the HPMC. I am not going to aspirate behind the lens. I just tap on the lens and bring out all the HPMC and put in my intracameral antibiotic, and before coming out hydrate the wounds. Just hydrating the wounds, making sure that there is no sudden collapse of the chamber. And incidentally, the patient did extremely well. So pretty happy with the case. Thank you so much for watching.